So our topic is amblyopia, practical tips for evaluation, diagnosis and management. So I will be talking introduction, classification and amblyopia related to refractive error. Dr. Laila Mohan from Comtrust Hospital, she will be talking on amblyopia related to strabismus. Dr. Elizabeth Joseph, HOD of Little Flower Hospital, Angamali, she will be talking on stimulus deprivation amblyopia. And finally, Dr. Sanjita Satyan, she will be talking on advancement in the management of amblyopia. So what is amblyopia? Yanov has given a definition. Amblyopia is a developmental defect of spatial visual processing that occurs in the central visual pathway of the eye. Jacobi has given another definition. Amblyopia is literally a dull sight. It is a disorder of vision, the most common cause of visual loss in infants and young children, which demands diagnosis and treatment within the first decade. Anyway, it is a lazy eye, a disorder with visual deprivation or dysfunction of the processing of visual information. Usually unilateral, it can be bilateral diminution due to cortical developmental defect. Von Graff has given a practical definition, that is a condition in which the observer sees nothing and the patient sees very little. So amblyopia classification based on the etiology, most important cause is strabismus, about 38%. Refractive error about 37%, can be ametropic, anisometropic or meridional or astigmatism. Or can be a combined form of strabismus and refractive, that is about 24%. Our third important cause is stimulus deprivation amblyopia, that is media opacity. It is also called amblyopia exanopsia. Other minor causes are organic causes, too much occlusion for amblyopia treatment, hysterical, idiopathic, toxic, these are minor causes. So differential diagnosis, before going for diagnosing the amblyopia, you have to differentiate. You have to rule out any visual pathway pathology, optic nerve involvement, visual cortex, etc. You have to rule out any corneal pathology, mainly undetected keratoconus or any lendiconus or lens opacities, or in children can be some toxoplasma or toxocaria affecting the macula, or can be undetected tumor like glioma or pharyngioma. So for diagnosis of amblyopia, complete ocular examination is mandatory. Three essential factors are essential for diagnosis. Most important thing is reduced visual acuity, either unilateral or bilateral. Second is evidence-based evidence of amblyogenic factors, just as I told you, stimulus deprivation, strabismus, and refractive error. And you have to rule out that there is no other cause for visual loss on examination. Then only you can make a diagnosis of amblyopia. And the grading of amblyopia based on Fels criteria, mild amblyopia, visual acuity between 6.9 to 6.12, moderate amblyopia, visual acuity between 6.12 to 6.24, and severe amblyopia between 6.24, less than 6.24. The goals of amblyopia therapy, you have to present a clear retinal image to the amblyopic eye by eliminating the cause of visual deprivation or corrected refractive error or squint. Make the patient to use the amblyopic eye by patching, by occlusion or penalization. To treat the amblyopic eye as early as possible, that is the most important thing. Irrespective of age, all children should be treated. Treatment of all the children can be little bit liberal. American Academy of Ophthalmology preferred practice pattern of amblyopia recommend treatment should be considered up to the age of 10 years. And pediatric eye disease investigation group, they recommend that it should be up to 7 to 17 years of age. Ideal age is before 8 years of age. And if there is no response to treatment after 6 months, do the other further investigation like electrophysiology, EEG, ERG, etc., or imaging technology to rule out any structural or organic causes. And compliance of amblyopia treatment is most difficult because the too much treatment for prolonged treatment cause distress to the child and the family. And too much patching and occlusion will cause skin allergy also. And poor parental understanding, because you have to explain to the parent, generally follow-up should be possible. That require positive reinforcement and parental commitment. Regression after sessions of treatment is very common. So amblyopia eye monitored for regression, and regression rate is between 17 to 95% by various studies. And PDE study recommend that it is about 24% regression is possible. If you have too much patching, it is not tapered, regression rate is about 42%. If the patching is tapered, regression can be up to 14%. So weaning of treatment and close follow-up is very, very essential for treatment of amblyopia. Now I come to the second topic, that's amblyopia due to refractive error. And it is less compared to strabismus. First important cause is strabismus. And it is commonly missed because less symptoms are there, so the parents may not be aware of the refractive error. Unlike the squint, which is manifest and parents will notice that. So because it has less dramatic appearance in refractive error, lack of obvious physical manifestation unlike strabismus. So it is too often undiagnosed and untreated. So refractive error etiological classification, mainly it is isometropia or ametropia. That is an optical state with equal refractive error in two eyes. Anisometropia means total refraction of the two eyes is unequal. And meridional means uncorrected astigmatism. One diopter difference in refractive error causes 2% in the size of the image. So up to 5% image size difference is tolerated. That means 2.5 diopter difference will be tolerated. Up to 4 diopter may be tolerated. More than 4 diopter is not tolerated. So epidemiology and pathogenesis, amblyopia rarely occurs older than 5.5 years and usually reversed by therapy treatment. May reappear after the age of 9 to 10 years. That's the problem for amblyopia. For amblyopia to occur, anisometropia must be present for more than 2.5 years. So we come more details about anisometropia amblyopia. It is a decrease of best corrected visual acuity in one eye, that is undetected amblyopia. Significant difference of refractive error between two eyes may be associated with anisoconia. Second cause is ametropic amblyopia, that is significant bilateral refractive error. So usually hypermetropia more than 5 diopter cause amblyopia, myopia more than 10 diopter because near vision is not much affected in myopia. And astigmatism is more severe, more problem because astigmatism more than 2 diopter can cause amblyopia. Usually early detect and treated in ametropia because it is a bilateral condition and parents will notice that. Meridional amblyopia is a special form of anisometropic amblyopia, uncorrected astigmatism either unilateral or bilateral. It is due to spatial resolution of the eye in selected meridians. So etiology of anisometropia, usually congenital or developmental because of the difference in growth between the two eyes. It can also be acquired like univocal aphakia, calculation of IOL correction problem or refractive surgery errors or trauma to one eye or following keratoplasty of one eye. So that are causes for acquired unilateral anisometropia. Anisoconia, that's the ocular image, unequal in size and shape or both. It can be due to optical, retinal or cortical causes. It can be symmetrical or asymmetrical. Symmetrical means different size and asymmetrical means different shape. It mainly causes astronomic symptoms. So clinical types of anisometropia, it can be simple, compound or mixed. Simple means one eye normal or ametropic, other eye myopic or hypermetropic. Compound means both eyes myopic or hypermetropic, one eye high refractive error than the other eye. Mixed means one eye myopic, other eye hypermetropic. That is also called antimetropia. So clinical types of anisometropia related to astigmatism, it can be simple astigmatic, that means one eye normal, other eye myopic or hypermetropic astigmatism. It can be compound astigmatis, that is both eye astigmatism but of unequal degree. Mixed astigmatism means one eye myopic astigmatism, other eye hypermetropic astigmatism. What are the clinical features of amblyopia? Most important thing is visual loss. So that is a hallmark, decreased visual acuity. So to make a diagnosis of amblyopia, visual acuity should be less than 6/12 in bilateral amblyopia. A difference of 2 lines in unilateral amblyopia. So if in unilateral amblyopia, the child will resist to close the better eye. Other clinical features are defective stereo acuity, fixation reflex may be reduced, crowding phenomena, eccentric fixation, contrast sensitivity loss. These are other clinical features. To make a diagnosis, most important thing, as I told you, defective vision. Then refractive error should be detected by retinoscope, and state of vision assessed by front test or with four-dot test. So cycloplegic retinoscope is very mandatory. It depends upon the age. You use atropine, cyclopentate, or homatropine. And all the children, you can do subjective refraction also. So front test, you keep the diplopia goggles, red in front of the right eye and green in front of the left eye. And binocular single vision, child will read front. In uniocular vision, either child will read fin or red. Alternate vision, child will read fin or red alternatively. So to make a diagnosis of amblyopia due to anisometropia, the hypermetropic refractive error difference should be more than 2 diopter, myopic refractive error should be more than 4 diopter, and astigmatic refractive error should be more than 1.25 diopter. So what are the treatment options available for amblyopia? Most important thing is correction of refractive error. Second one is occlusion. Other things are more of theoretical importance like penalization, pharmacological treatment, near visual exercise, preoptics, calm stimulation, refractive surgery, acupuncture. These are all theoretical importance only. Anyway, Dr. Sanitha will enlighten more about that. Treatment depends upon the age, type of amblyopia, and cooperation of the child. Refractive correction is the most important things. Different amblyopia treatment study group report that amblyopia resolve in 27% of children after treatment. Two-line improvement is seen in more than 77% of the children. And proper cycloplegic refraction is mandatory, as I already told you. Prescribe adequate optical correction. So isometropia, you should have a myopia and hypermetropia. If there is more than 4 diopters, you should be treated. Hypermetropia with esotropia, you should have a very aggressive treatment, more than 1.5 should be treated, and astigmatism more than 2 diopters should be treated. If the anisometropia, it should be more strict. Myopia and hypermetropia more than 1 diopter should be treated, and astigmatism more than 1.5 diopter should be treated after the age of 3 years. Anisometropia treatment, glass, full correction of each eye should be given. Spectacle tolerate up to 4, as I told you, 4 diopter difference. More than 4 diopter may cause diplopia, then you have to go for contact lens. Children up to 12 years, full correction should be given. So more than 4 diopter, go for contact lens or anisometropic spectacles. When you are treating an adult with amblyopia, you can have a little compromise, best correction with the least discomfort, because the adult may be used to have no glass for many years. More ametropic or poor eye should be under-corrected. If it is a 3 diopter and 7 diopter between 2 eyes, you give +3 for one eye and +5 for other eye. Or you can give both eye +3. If this one eye is hypermetropia and the other eye myopia, the hypermetropic eye can be used for distance and the myopic eye can be used for near vision. Treatment of uniocular refractive error. If it is due to aphakia, you give a IOL implantation. If it is patient cannot tolerate spectacle unacceptable or anisoconia or contact lens intolerance, then you go for a refractive corneal surgery. If there is a very high myopia, you can think of crystalline lens removal, or you can go for an intraocular contact lens or ICL. So refractive correction, special points you have to think. Hypermetropia with esotropia, full cycloplegic correction should be given. Esotropia with high AC by A ratio, executive bifocal can be considered. Myopia, always go for under correction in small children. But if it is associated with exotropia, full correction should be given. Astigmatism, full correction should be given. Anisometropia more than 3 diopter or 4 diopter, go for contact lens. And bilateral aphakia, you give over correction for one eye for near vision. So after refractive error correction, second choice is occlusion for amblyopia. So no shortcut or substitute for occlusion. It is a gold standard for amblyopia treatment after refractive error correction. The mechanism of action, it forces the child to use amblyopic eye. That will inhibit the inhibitory impulses arising from the sound eye. So occlusion therapy, I am not going into much details. You have a full-time occlusion should be given in a bilateral amblyopia. And moderate amblyopia, 2 hours to 6 hours occlusion should be given. And severe amblyopia, 6 hours to full-time occlusion should be given. Different studies will suggest that the better the visual acuity, the shorter the duration of occlusion. If there is no improvement within 6 months after occlusion, there is no further occlusion should be given. That will not give any result. So regarding the occlusion protocol schedule, depends upon the age, occlusion days can be vary. Start with, it can be 2 days occlusion in a week with a 1 day occlusion of the amblyopic eye. As age advances after the age of 6, you can have a 6 days occlusion in a week and a 1 day occlusion of the amblyopic eye. If you cannot do occlusion, you can do a pharmacological occlusion like atropine. If patient is non-compliant to occlusion or alternative to occlusion, so it can also be given as a first-line treatment also. Atropine can be a daily administration or intermittent or weekend atropine therapy can be given. Or you can give a overplussing lens, the good eye, you can give a high plus lens so that will suppress the good eye. That vision will be of the sound eye will be blurred. There is also a lot of research going on drug therapy. Dr. Sanida will deal that more. So supplemental drug therapy like oral levodopa or carbidopa, citicoline, etc. But only very small effect and usually it will regress. No clear benefit of routine use. Other forms of treatment are game therapy or pleoptic therapy, calm stimulation. There is no other advantage or occlusion. The first line of treatment is spectacle, second one is occlusion. Then only all these things. Good prognostic factors in amblyopia are younger the age, better prognosis. Depends on the type of amblyopia also. Better prognosis is strabismus, followed by anisometropia, and finally stimulus deprivation or media opacity. Myopia have a better prognosis than hypermetropia because the near vision is not much affected. The patient has a good vision pre-treatment that will have a good prognosis, and the good patient compliance is the most important things. So thank you very much. Okay.
Hello. Thank you very much, Dr. Anthrayose. That was a very exhaustive presentation. First an introduction and then anisometropic amblyopia, refractive type. That was a very nice presentation.